So a very warm welcome to all of you for this session titled Reclaiming the Cairo Agenda, Demanding Accountability for Sexual and Reproductive Rights through Bottom-up, People-Centered Accountability Practice. This session is being organized by COPASA, which stands for Community of Practitioners for Accountability and Social Action in Health. COPASA is a South-led network of practitioners and researchers using accountability approaches to strengthen the linkage between communities and the health system to provide quality and accountable care. For more details on COPASA, do visit our website, which is www.copasa.net. I am Renu Khanna, and I am one of the founding members of COPASA and on the present steering committee. For years, decades actually, I've been working on community-based health programs with a gender and rights perspective. And it is my pleasure today to be chairing this session with some very illustrious speakers, my colleagues from COPASA. We have 3 speakers today. All of them are members of COPASA, and they will be presenting the struggles of the marginalized communities with whom they work to realize their sexual and reproductive rights. And I hope that we have also with us other members of COPASA, current and potential, attending this session today. I recognize, given the nature of this symposium this time, that we are missing many friends from across the globe. In India, at this point in time where I am, it's 2:30 p.m. But my colleagues in Latin America, Ariel, who's here with us, for him, it's midnight. And for many of our other friends, it's probably midnight. Let me now take 5 minutes to frame our discussions during the next 75 minutes. As the title suggests, that the ICPD International Conference for Population and Development in Cairo in 1994, after many protracted struggles, promised us a remarkable set of reproductive health rights, which were further developed in the Beijing Women's Conference in 1995 as the concept of sexual rights gained some acceptance. The gains of these 2 seminal conferences gave a lot of energy to feminists and LGBTQI groups. All of this is part of my own lived history, and that's why I'm able to talk about this quite passionately. But we've seen over the last 25 years that the rhetoric of sexual and reproductive health rights has not matched the implementation on the ground. And there are several reasons for this. For example, the Millennium Development Goals diluted the gains made in the ICPD, the required emphasis and commitment on SRHR was missing from the MDGs. Other global initiatives like Family Planning 2020 and the SDGs, Sustainable Development Goals, brought back attention to certain SRHR issues like access to contraceptives, universal access to sexual reproductive health services, and sexual and reproductive health rights. But there have been some adverse consequences of some of these initiatives also. For example, the focus on quantitative targets that the Family Planning 2020 set have led to some degree of coercion, as we will hear in the India presentation. Similarly, while the SDGs talk about leave no one behind, the Peru and Romania presentations will talk about the struggle of marginalized groups to realize their reproductive and sexual health rights. Access to safe abortion services, adolescent sexual and reproductive health rights, including comprehensive sexuality education, suffer at the hands of health systems as well as certain community mindsets. ICPD clearly called for male engagement in reproductive health, but we see that precious little has happened on the ground. Clearly, we hardly see any large-scale programs working with men on sexual and reproductive health rights, including their own sexual health issues or addressing gender-based violence. These call for programs that start early on transformative masculinities with young boys, with adolescent boys, but we see only pilots outside of the health systems. And while accountability is increasingly featured strongly in the global health discourse with the setting up of mechanisms like Countdown 2030 and the Independent Accountability Panel, the dominant paradigm appears to be one of vertical accountability within public systems and not accountability of systems to the users, to citizens, including marginalized groups. So today's session, which will be kick-started with 3 illustrative presentations on citizen or community-led accountability in 3 very different contexts, we hope that the discussions will take us to what lessons can be learned from the presentations, as well as from your experiences for knowledge building, policy formulation, and accountability practice. So after the presentations, which are going to be between 8 to 10 minutes of pre-recorded presentations, we will have discussions. And for the discussions, I would urge you to use the Q&A function, the live Q&A function on your portal. Please keep inputting your questions and we will be looking at them. And after the presentations, we'll have a discussion on those questions. And we will end the session with drawing the discussions to a close with a 5-minute summary. So this is the design of the presentation of the session. And I'm sure we're going to have very rich discussions. So may I now request, let me just give you an overview of the 3 presentations. We have Eugene Gita from Romania, who will speak about the case of Roma people and the kind of discrimination that they face while accessing sexual and reproductive health services, and the ways in which the work of Roma Just, of which he is a member, challenge some of these difficulties that they face. Sana Contractor from India will be speaking of the context of coercive family planning in India and the rights-based strategies being used by health rights networks in highlighting violations, bolstering community voice to reject targets, and improve quality of care, as well as access to safe contraceptives. Ariel Frisancho and Luz Estrada. Luz is not present with us today because of illnesses in the family. Will be speaking of ways in which indigenous women's organizations have engaged with the Peruvian Ombudsman to monitor women's health rights, particularly the right to good quality, appropriate, and culturally respectful maternal health services. So with this overview, I would now like to have Eugene's presentation. Eugene is a human rights monitor for Romania since 2009. He is the founder and president of Roma Lawyers Association, Roma Just. He's been working as a human rights monitoring expert, community facilitator, mentor, and project manager, mainly for the nonprofit sector, in the fields of human rights, fighting discrimination, social service, awareness campaigns for right to education and culture, housing, and identity. Eugene has a university degree in law and a master's degree in European administration, institutions, and public policies. Eugene's presentation, please, if we can begin with that. Thank you very much.
Hello everybody, I am Eugene Gita from Romania and I will present you a small presentation about the sexual and reproductive rights for Roma women in Romania. The main challenges which is faced by them, it's internal and external ones. The internal challenges, it's 85% of Roma women do not work. They are housewives and consequently they do not have a health insurance. Due to the pandemic and not only, many doctors prescribe treatment to Roma women without actually consulting them because of the fear of getting infected. Very few Roma women go to gynecologic examination without of pregnancy. 42% of them have not heard about the pap smear test. Only 28% to the woman who heard about pap smear test did it. The external challenges, lack of coherent government strategy for the Roma community, the European Union directives on Roma health and discrimination issue are not properly applied. Roma women are discriminated in the medical facilities, and the pandemic created even a bigger gap in having access to medical services for the Roma population. Review and study of pregnancy experience of Roma women. Many Roma women encounter barriers to accessing maternity care. They can experience discriminatory mistreatment and the basis of their ethnicity, economic status, place of residence, or language. Some health professionals held underlying negative beliefs about Roma. Roma women often experience multiple disadvantages and have poor maternal and child health. Roma and other marginalized women in Romania have poor healthcare experience due to low health literacy, especially about the prenatal health. The economical barriers to accessing maternity care is unaffordable transport, no health insurance. Although all women in Romania have free antenatal care after they register their pregnancy with a physician. They must pay for this first visit if they are uninsured. Women who had insufficiently funds were susceptible to delaying care. Inability to pay for the prenatal care also prompted discrimination from some providers. Individual and societal discrimination against Roma women is widespread, especially in healthcare. Professionals drew a distinction about the discrimination faced by Roma women who were viewed as more traditional. Several professional and mothers described physicians who refused to care the Roma for Roma patients. Discrimination also impacted the quality of care women received during labor and delivery. Women were often sent an inferior ward if they were Roma and poor, while segregated maternity wards are illegal. Hospitals have been able to avoid the legal repercussion from their practices. An outrageous case on the part of some parliament representatives was that they wanted to propose a national directive on the sterilization of Roma women. For the start, they made public announcement to pay $100 for each woman who accepted the sterilization. That led to a major scandal between Roma civil society and the Romanian authorities. Following this scandal, several women were sterilized without their consent in several hospitals in Romania. The field work gave us the opportunity to find out about the sterilization, but also about many cases of medical praxis. The Roma Just intervention made possible the punishment of the politician for promoting fascist ideas and many doctors for malpractice. What we do more, like organization, was to have meeting with the marginalized group, and they receive support and legal advice from our NGOs. They are referred to the right institution that can address their issue, and they use the help on the work group within their community. We made the group work community with the school principal, family doctor, social worker, community assistant, health mediator, a representative from the police, representative from the National Health Insurance Agency. In the conclusion, Roma Justice established legal incubators in university centers where students and graduates of law schools Roma provide legal services to community members to empower them to solve their problems alone or with a network of human rights monitors. A human rights-based approach to address maternal mortality and morbidity identified that targeted measures are required to ensure the rights of marginalized groups. Roma health mediators focus much of their time on pregnancy and family planning and work with women to increase health literacy around prenatal care, and they can offer them access to other professional key needs, medical provider, human rights monitors, social workers, etc. Reproductive rights and family planning services should be accessible and affordable for all will improve sexual education among Roma parents and prevent teenage pregnancy and births. Research studies should be made to examine the effectiveness of intervention to address discrimination against Roma women in their infancy in Romania and Europe. Thank you, and I will be able to answer for your questions in the session Q&A. Thank you.
Thank you very much, Eugene, for your presentation. You've highlighted human rights violations as well as reproductive rights violations in your presentation, with the incentives for sterilization and lack of consent. And these are some of the themes which will be echoing in Sana's presentation also. I would urge friends who are present, and not too many are in the room, to put your questions for Eugene in the Q&A box, and also to put in your own observations about some of the lessons learned from your own experiences so that we can have a good discussion after these presentations. I would now like to introduce Sana. Sana Contractor is a young feminist researcher in India, and she's an emerging leader in the area of sexual and reproductive health and rights and health policy analysis. She's not able to join us today. Last night, we received word from her that she has to be visiting the hospital because she's got COVID symptoms. However, we do have her presentation, which was pre-recorded, and I'm requesting Julie to please put that up. Thank you. I am also, thanks a lot. I will now go off.
Hello, my name is Sana Contractor. I'm based out of Mumbai and I'm here representing COPASA and presenting the work of the Center for Health and Social Justice in New Delhi. My presentation will look at the efforts of CHSJ in addressing the need for rights-based contraception in India, and I will reflect on these strategies a bit historically in light of the commitments made during the ICPD in 1994, as well as the current environment both globally and in India. To begin with, a short intro to the context of contraception in India. India has one of the oldest contraception or family planning programs in the world. It was conceptualized and born at a time when population control was the emphasis both globally and domestically. It is worth remembering that the origins of the program were with this mindset, which had an invariably eugenic bent, in that it was an attempt to control the population of certain countries when viewed globally and certain populations when viewed domestically. This history is important because its influence can be seen in the program even today, and a lot of the recent resurgent cries for population control also re-emphasize this. The major areas of concern with the program are with the operationalization of informed choice and quality of care. India has a long history of coercion in the program, manifesting both as outright forced sterilization, as was seen in the 70s and 80s, as well as more indirect ways, such as providing targets based on demographic goals, to health workers and health departments, and incentives to users, providers, and motivators. There are also a range of disincentives for those who have more than 2 children, known as the two-child norm, including being barred from promotions, participating in elections, access to certain schemes, and so on. Further, although the program has a range of contraceptive options, in practice, the method is not chosen as much as dictated by the system. Mostly female sterilization is what is practiced and also forms the bulk of the budget. Recently, there has been a shift towards using postpartum IUCDs and a greater emphasis on male methods, especially male sterilization, but both are ridden with similar problems of coercion and sometimes even stealth procedures being performed on women. Quality of care has been an area of great concern, especially the non-adherence to SOPs, inability to maintain infection control, improper screening and follow-up, insufficient infrastructure, and excessive caseloads. These have sometimes led to complications and even deaths of women. Finally, the most limiting aspect of the program is the fact that because it is driven by a demographic paradigm, it sees contraception as relevant largely to married couples, not as a matter of choice to single persons per se. It is important to mention here that historically there has been engagement and contentions between civil society rights-based groups and the state vis-a-vis the family planning program. Social movements, especially the feminist movement and the health movement, have raised these concerns repeatedly as the program has changed its form. Right from the 80s, these movements have challenged the state's paradigm of population control and questioned the disproportionate focus on family planning, even as other issues of women's health were being neglected. Aspects of consent, choice, and quality of care have been major contentions, and there was also a great opposition to the introduction of methods that had the potential to harm women's bodies in the quest to control population. After the ICPD in 1994, the government changed its stance on coercion, moving towards what was called a target-free approach and a more comprehensive approach of reproductive and child health rather than the singular focus on family planning. While this shift in approach was indeed positive, on the ground, targets continued to operate and demographic goals were being set irrespective. Quality of care for female sterilization also continued to be substandard, and guidelines, although present on paper, were not being followed in practice. At this time, sometime in the early 2000s, an intervention in the Supreme Court was initiated to address the lack of quality of care, and it led to some positive developments, including an order to implement all guidelines and also the institution of a compensation and insurance scheme to ensure that those who suffered complications or deaths as a result of sterilization would be provided compensation. When this order was also not implemented stringently and deaths and complications continued to take place in camps, another case was filed in the Supreme Court which led to an order putting a moratorium on camp-based sterilization and reiterated the need to follow guidelines and accountability. Alongside this, civil society organizations have also closely been involved in global processes to expand access to contraception, including the FP 2020, and in these forums they have consistently highlighted to look more closely at consent and choice in addition to expanding access. With this background, I now want to talk for some time about community-led accountability strategies that have been adopted by CHSJ to synergize with some of these developments in recent times. These interventions are within the time frame of the past 5 to 6 years, and the goal has been to build community empowerment vis-a-vis a rights-based approach to contraception and foster evidence-based advocacy by communities to improve quality of care and adherence to informed choice. Efforts begin with building a consciousness of contraception as a right from a gender and human rights perspective, including dialoguing around issues of autonomy and choice of women, rights of unmarried persons, and responsibilities of men vis-a-vis contraception. This is typically done through group education with both men and women and formation of collectives to build a demand for rights-based contraception. Evidence is built by communities on the status of services in their villages, blocks, and districts, and various methods have been used to do this. The use of scorecards, monitoring camps, using a checklist or camp watch, doing in-depth documentations of violations, and so on have been done. The evidence generated is used for various forms of advocacy, including public hearings at the facility, district and state levels, submissions to various ombudsman offices like the Human Rights Commission, Women's Commission, and so on. In some instances, the evidence has also been submitted for ongoing legal interventions. Civil society networks have also used such evidence to raise concerns around quality of care and choice at global forums, such as during the Universal Periodic Review, This advocacy is bolstered by building alliances across actors, including community leaders, media, academia, and NGOs, but also across common interest collectives. For instance, the issue of two-child norm is of interest to those working on local governance, since the policy bars those with more than 2 children from contesting elections. Such common ground also helps to build broader alliances and strengthen the demands. These efforts have led to various kinds of outcomes, ranging from greater appreciation of contraception as a human right among communities, especially with respect to a demand for rights-based services, and greater appreciation of male responsibility vis-a-vis contraception, to very direct action taken to address violations at the ground level, such as compensation to those who have suffered complications, failures, or deaths, better adherence to guidelines, especially vis-a-vis sterilization, better counseling, and a reduction in coercion by community health workers. But there are upstream issues that also hinder these changes. For instance, in one field area, we found that due to the pressure from communities, coercion for sterilization reduced. But since the health worker still had to meet her targets, she would procure her cases from elsewhere. Similarly, when OC pills and condoms are available, health workers have begun distributing them, but when there is a lack of supply, not much can be done at the community level. The consistent efforts to highlight violations have kept the issue visible in the media. One of the most important outcomes, I think, of community-led work has been that as policies emerge and new monitoring guidelines are introduced, communities are directly able to observe how they play out in practice and point out violations that are taking place. So when there was a deliberate shift to using postpartum IUCDs, for instance, communities began to report how IUDs were being stealthily placed in women after delivery. Similarly, with the push towards male engagement, we also began to hear of men who were beyond the reproductive age being sterilized to meet targets. Such information provides important feedback to the government to be able to hold authorities to account. Finally, I want to reflect for a minute on what this means for the agenda of realizing the right to contraception 25 years after ICPD. It is worthwhile to recall that ICPD positioned family planning within the paradigm of autonomy, choice, and rights. However, both globally and domestically in India, we see today that the focus seems to have been reduced to access on the one hand, and the pressure to control population continues to have different drivers. In India especially, this is seen as a resurgence with religious fundamental overtones. Sexual autonomy and choice are cornerstones of SRH, and alongside the issue of access, it is imperative that these be given attention. Otherwise, the rights of individuals outside of the paradigm of procreation will not be addressed. In many of our countries, we are also seeing a breakdown of trust between communities and the state, and this often leads to pushback, which is detrimental to women's rights. If contraceptive programs are truly intended to achieve their goals, then they need to rebuild this trust. And lastly, with the COVID-19 pandemic, we saw that contraceptive services had been stopped for several months, and now there must be an enthusiastic resumption of services. But alongside this, it will also be important to monitor quality of care and informed choice in a bottom-up manner. For all these reasons, it is critical that communities of all types be center-staged so that programs and policies are better catered to their needs and services are implemented based on trust. Thank you.
So thanks to Sana for this extremely comprehensive, although rushed presentation. Masuma was requesting that this go a bit slower, but because of pre-recording, all the stuff that she had wanted to put in a very comprehensive way had to be sort of rushed through. Our apologies for that. But Sana's presentation gave a historical as well as a global context to what is happening on the ground in India as far as contraceptive program is concerned. And the fact that the contraceptive program, and they insist on still calling it the family planning program, is excluding certain populations is actually a violation of reproductive rights of those communities, young people in particular. Let's move on now to our last presentation of the day. I'm noticing that no questions are coming into the live Q&A box. If you don't want to use that and want to use the chat box, please do that. Unfortunately, we don't have the facility of verbal communication in this portal. Although there are not too many of us present in the room, we won't be able to communicate verbally. So okay, Masuma's comment has come in. We'll take it up a little later. Let's now go to the last presentation, which is Ariel and Luz's. Ariel is the CMMB Peru's country director since 2015 to present. He is an MD and an MSc on health policy and planning and financing. He is a specialist on rights-based approaches, citizens' participation, community health, health governance and accountability. He's written widely in international publications on these issues. He is also a member of the steering committee of COPASA, as well as other international collectives. So may we have Ariel's presentation, please?
Hello, my name is Ariel Frisancho, representing COPASA Latin American region. More than 25 years ago, authorities of 179 countries gathered at ICPD made strong commitments, among other key issues, on the reduction of maternal mortality, the fight for gender equity, and the strengthening of women's participation on policy decision-making. Although there have been remarkable advances in the reduction of maternal mortality, progress has not been homogeneous, and socially excluded groups are given fewer rights and entitlements than others, especially in countries as Peru, where inequalities are cruel and stark. My presentation today will try to summarize the results and lessons learned from an initiative of citizen surveillance of reproductive rights realization within health facilities of Puno, which is located in Peruvian Andes. In 2007, Care Peru and Foro Salud, the widest civil society network in health of Peru, began the participatory construction of a model of citizen surveillance for the respect of reproductive rights and quality of health services. Model to be spearheaded by Quechua women leaders engaged with local ombudsman to implement systematic monitoring visits to health facilities. In those visits, they register health system responsiveness. The purpose was holding health authorities and facility managers accountable on rights respect, looking for poor, rural women receiving the kind of health care services they were entitled to. After a series of capacity building workshops, each monitor received accreditation by ombudsman and planned visits to health facilities where they made direct observation and talked with poor indigenous women in their native language, navigating together within the health facilities. Based on their findings, they produced regular reports, and monthly those were analyzed with Ombudsman, Foro Salud, and CARE to prioritize the findings, both the good and the bad, building together a dialogue agenda. That agenda was quarterly presented to the healthcare networks, hospital directors, and health team to agree commitments of improvement. In an iterative process, citizen monitors visited the facilities to check the commitment's accomplishment. Another important element was the transversal social communication strategies and the information actions for the people and community authorities to be aware on the process and the results. Here we have Eusebia, one of the community monitors, one of the women leaders, explaining exactly this process in her own words and description. Some results of the experience were that we could establish together with the women systematic dialogue spaces where we could talk about what women expect from the service and both achievements and pitfalls of maternal health care provision. The identification of practices that were deterring women from utilizing services, like under-the-table payments, lack of information, mistreatment, limitations for access, cultural disrespect, and even obstetric violence. The construction of commitments to improve healthcare provision in terms of opportunity, treatment, information, language, access to medicines, and cultural appropriateness, and the improvement in maternal and child's care reflected in increased demand of services, increased provision of medicines and laboratory exams, and increased birth delivery at the facilities. However, the experience alerts us on health system challenges for reproductive rights realization. Among all, huge inequality gaps, which underlie the discrimination and exclusion that is still embedded in the state services. The overall lack of an accountability culture, and here we have to ask, accountable to whom? But accountable how? Who are involved? Who have the voice? The unequal power relations and the existence of invisible barriers day-to-day right disrespects that are not reflected in the mainstream policy discussions. The paradox of having good sustainable development goals metrics coexisting with social exclusion. This historical social divide that normalizes an unequal treatment to those in subordinated position in power relations leads to social exclusion, and social exclusion of poor, indigenous women impacts on equity and undermines progress towards ICPD recommendations. So, which were the factors that we consider were important for the success of these experiences? ICPD highlighted the importance of women-centered approaches. Therefore, listening women's voice and understanding their beliefs was a cornerstone. Together with building a common understanding on life and health, one of our first challenges was how to explain abstract concepts such as human rights, transparency, or accountability. In the Andean world, the Quechua language focuses on things that exist, things that are tangible, that you can see and touch, and this is reflected in its vocabulary. It is not easy to explain the nature of concepts that cannot be measured. We needed to show those concepts with examples. One topic that led us into reflection, however, was that they often seem to connect the term rights with benefits. Actually, an equivalent word in Quechua did not exist, not only the idea of rights but the concept itself. As part of indigenous populations that have historically suffered from poverty, exclusion, and discrimination, there was a generalized understanding of the actions of the health system as a favor or a concession that someone more powerful used to grant. Together with learning to listen, we had a process of information provision, of capacity building on health rights, health entitlements, health system norms for participation, and which are the organizational arrangements that lie behind the provision that is given to the provision of services that is given to women, indigenous women. A third factor was the coalition building, with the strategic partnerships both on the private sector with civil society organizations and the public sector with ombudsman and even the representatives, local representatives of programs of the Ministry of Health that supported this initiative. Important is also raising concern for collective action, with community people informed and aware of their rights and entitlements. The progressive reduction of mutual mistrust between health providers and community leaders, community women leaders, and the advocacy strategies set by CARE for Salud in other levels to propel political will and subsequent action. We have to remember that Sustainable Development Goals framework relies on weak voluntary measures for accountability, not institutionalized obligatory accountability measures. Therefore, we need to ask, how does an accountability enabling environment would look like? First, we need the political will, translated into context-appropriate finance institutional mechanisms. We need informed citizens on their rights and entitlements, and here the role of media and academia is a key role in terms of propelling a burning platform the sensation of urgency of these things that should not continue happening to women, indigenous, poor women, that are at the end the most excluded of the excluded. We need accountability mechanisms, institutionalized policy dialogue and accountability spaces with clear participatory roles of the game, capacity building on both sides, responsiveness and binding decisions. And finally, we need voice with strategic allies. As Professor Jonathan Fox of American University says, we need vertical integration towards the construction of a sandwich strategy with local action, bottom-up voice, articulated to subnational and national needs. Thank you very much indeed for your attention, and I hope in the questions moment we could amplify, we could extend our conversation. Thank you very much.
Thank you very much, Ariel. You have in your presentation highlighted some very important and necessary conditions for accountability in the way we in COPASA have defined it and in the way we are trying to practice it. The importance of voice was highlighted in your presentation. Vocabulary, concepts and vocabulary. I think in our Western education paradigm, some of these concepts are very clear to many of us, but actually at grassroots community, at the grassroots community level, we have to actually learn about their concepts. How do they recognize what we term as rights, for instance? The other point that you made was on addressing power inequalities between healthcare providers and users. And what are the various strategies and mechanisms for doing that? What are the mechanisms for inclusion? What are some of the enablers for inclusion? We need to have a discussion around that. And the important point that you made about going beyond tokenism and rhetorical discourse around accountability to political will. And I think these are some of the themes which you spoke about. And all the three presentations were highlighting strategies such as monitors, ombudspersons, community organizations, and the point that we need to go beyond tools to create a culture of accountability, which means that there has to be capacity building, which requires financial allocations and investments. And this has to be one of the demands that many of us feel has to be made. So I would now like to open this up. There is one question from Masuma here, and she says, are there any special efforts of engaging men at all levels to promote dialogue on addressing unequal power relations on issues linked to decision-making, choice, and reproductive and human rights? So would Ariel or Eugene want to respond to this question? If you can also put on your cameras and unmute yourselves. And I'm wondering, is it possible for the participants to put on their cameras? Could we see everybody in the room? Is that a possibility? The attendees, could we see them? I don't know. Maybe 1 minute. Let me see if Julie can guide us on that. Okay, Ariel, would you want to respond to Masuma's question?
Yeah, I think Masuma's question is paramount.
Okay.
The engagement of men in addressing unequal power relations and recognizing the need of downplaying their own power relations in general practice is very important, and it's a challenge because we still, at least in Latin America, don't have that culture. Even in if you analyze health systems and the health institutions, organizations, there's a hierarchical, a vertical approach of management in which medical doctors, usually men, are the leaders, and other professions that, like nurses or midwives, are subordinated, and there's not much possibilities of seeing women on top of the leadership. And that gets replicated on the attitudes. Whenever they address the community, women are seen as helpers of the facility work, not as equals. There's little dialogue spaces. It's more, help me to make my work, and you are going to be recognized for that. It's not, what do you think about my work? It's not, how do you assess my work? So engaging men in the fight to equalize power relations, especially those that are deterring women from participation, is a process to be promoted, and it needs to be explicit. It needs to be verbalized, because many times what is written on papers or even in legal norms is not a mandate, is not respected. And if it is not a mandate and it's not mentioned by the authorities, and if there's not at least some kind of plan of advocacy and strategy to do that, we are not going to get it. And thank you for that question.
Okay, thank you. Eugene, would you like to say something in response to Masuma's question on working with men?
Yes, so when it comes about the Roma community, there exists from years ago the patriarchal rules. So when it comes to bring the men for our working groups, that was a big problem. We had some statistics on that, and I can tell you about the contraceptives rules in family. 45% of husbands does not want the contraceptive, and exists another rule about the mother-in-law do not agree to have contraceptive. So it's very difficult to bring them together in the groups and to work. But I think how to bring that in public agenda, how to involve men in the policy practice, that it's a good example, if it exists somewhere, to see from our audience, if someone can give us some example, or from Romania, I can tell you we do progress in that. So it's very important to bring them, because it depends the life of women from the family. So that it was my comment. Thank you.
Okay, thank you. Is there anyone else who's present here with us, Sarah or someone else, Beth? Would you like to respond to this question through the chat function? Unfortunately, we won't be able to hear you, but if you can chat, put in your responses in the chat box. Meanwhile, I'll go to Masuma's next question, which is on any good examples to share on moving from tools to realization of accountability, horizontal and vertical. So moving beyond tools to, and I actually think that the examples that were presented here in terms of, the Peru example of, and citizens monitors, and, the Eugene's example, and Sana's example of mobilizing community groups to monitor contraceptive services. I think these are some examples, and the problem is that, and this is a problem also, I think, with the whole domain of male involvement or men's participation, is that all of all of this is actually micro level examples, small examples in small, geographical areas, but having profound effects at that level, at the subnational level. There are some very profound effects that we see from our COPASA practitioners, from their practice around sexual and reproductive health and rights accountability. And similarly with men's engagement, I think increasingly there are so many efforts which are happening outside of the formal system. And that is what my complaint is all about, that it's all happening outside of the formal health systems or the educational systems, and not enough is happening and not enough investment is made. So there are, groups like Promundo, like Sonke, like in India we have Maswa. So there are men's, engagement groups, organizations who are actually working with men as responsible partners, as responsible and caring fathers. The whole point that I was making about transformative masculinities. The thing is that I feel that all of this has to start much, much earlier. While young boys are in schools and within families, the culture of toxic masculinities has to change. And that can happen only if it begins very early and if it happens institutionally, through the education system, through the health system. In the health system, I'm taking a bit of a point, some time to respond to this, because this is a struggle that my organization, SEHED, Society for Health Alternatives, has been engaged with for, over 2 decades now. The whole point about having male health workers, like we've got the female health workers as frontline workers at the community level, we don't have the cadre of male health workers who will work not only on sanitation issues or malaria or immunization, but also work on sexual and reproductive health and rights, engaging with men and engaging with boys, not only in response to women's health needs, but also boys' sexuality related issues as they're growing up. So this is something that we've been advocating for over 2 decades now, but the investment just does not come. There is no seriousness about accepting this. Let me stop here now. Sarah is saying working with young male nurses, yes, engaging with boys and men. Are they increasingly? Yes, there are male nurses, but the problem is that sexual and reproductive health rights is not consciously being focused on with these male health nurses, male health workers, male health doctors, the male healthcare providers. That's not happening. It's not sexual and reproductive health and rights. It's not gender power relations, which is part of their curricula. It is, so how do we advocate for taking up sexual and reproductive health and rights? Could we get, by these male nurses, could we get some examples, please, or responses from Ariel, Eugene? I've been talking too much.
Like I said in my presentation, so we have the local action group work, and we can take the needs from down to up, and we made some public policies, but that it's in the local level. When it comes to national level, the political will is different. So there we have to have a great fight to put in the agenda that the community needs. So we can say we had success only in the local level, but in the national level, when we speak of the European level, the political will and the emergencies, it's different from the needs from community.
Yeah, I would like to add or relate Eugene's answer with the next question of Masuma. Thank you, Masuma. How we could pull together these specific local initiatives of success and link them to a bigger movement. And of course, your questions make sense. Because when we were talking about a sandwich strategy, taking the example of Professor Jonathan Fox, are things that we did with Puno experiences. Usually, the issue of rights disrespect or quality limitations are mentioned by authorities like anecdotal, like specific circumstances. There's a little research, and that's important for this symposium, on what this day-to-day rights disrespect within facilities, especially addressed to women, indigenous women, poor women, represent. This day-to-day disrespect is not reflected on the mainstream discussion of, for example, universal health coverage, no, or financing of health facilities, or lack of financing of primary health care. The overall importance of primary health care and the role it plays with for people in need is understated, unfortunately, in the policy discussion. So we need allies. We need to identify allies, advocates within the system in the different levels. When Fox talks about the sandwich strategy, I was thinking on things that the policy makers and the authorities in the national level mention, and then you come to a council or you make a note to the press demonstrating with explicit examples that what it is written in the norms is not being fulfilled in the practice, and it's not anecdotal. It happens here, 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 and you have the information. So we need to link the experiences and what they tell to us to advocacy, policy advocacy, and we need champions in the different levels, and there's civil society, but there are also state champions, and we need to find them. We need to analyze our strategies also as civil society organizations. And one thing that I would like to go further afterwards is how COVID-19 has somehow been a kind of X-ray on the real things that are happening at health systems. Because at the end of the day, access for care in COVID-19 has excluded the people that always have been excluded. Oxygen, intensive care unit bed, etc. The access to those equipment and resources have been more available to those who usually have more agency capacities, and some people have been left out. If we analyze what has happened in some countries like Peru, where primary health care was closed because somehow some kind of wrong decision of the government, and what this created and the consequences it has had for the poorest people, we could see how this experience is showing us that you could be very fair on sustainable development goals metrics. And this is also an alert to the donors. But what is happening inside the health system is really different. And I think we have more questions, so I will stop there to see the others.
So I think what Masuma is saying and what Sarah is writing and what Ariel has said point to that, our first question on what are the lessons learned for in the knowledge creation domain. And I think Sarah is pointing out that, and that's what Masuma was also saying, that all these very many local initiatives of success, what are the mechanisms and what are the contextual factors? So realistic research to identify what works in what context and use that for advocacy. So I think these are some very important points being made by all of you. And Sarah's also saying we need to grasp better what type of political advocacy is needed and at what point in time. That's right. Political advocacy at this time when COVID has actually highlighted health as actually a political issue now in globally, in all the countries. This was not the situation before in pre-COVID days. In some countries, health was a political issue, but in many countries, like for instance in India, health has never been a political issue. It has never been in the area, in the realm of political campaigns when political parties are campaigning for elections. And although many of us try to get it onto their manifestos, health is a right, it hasn't really worked. But now at the time of COVID, when the whole world is suffering and COVID is attacking not just poor people, of course, it's accentuated there, but also middle class and upper class people, it seems to be the right time for using it as, an instrument for political advocacy. When to resist and when to work with local authorities. Yes, this is extremely important. When do you engage and when do you call them out for their lack of accountability? So Masuma is saying, I think it would be really to pull together context-specific learnings. Yes, agreed. All of that. COVID exposed governance failures. Yes, absolutely. Inequities within countries, between countries have actually been accentuated. Yeah, absolutely. But the thing is that all of us as, health rights advocates now need to strategize and to work out our, our methods and our strategies for that kind of political advocacy that we're talking about. Yeah. Yeah. Absolutely. So some very interesting comments are coming in the chat box. And I see them mainly from Sarah and Masuma. So thank you so much, Sarah and Masuma. Is there anyone else who would like to respond?
We had also among the participants, Mary Bolivar. She made a very interesting presentation in a previous panel on accountability and financing. Probably she could share some of the lessons that she has. I also want to mention quickly that it's not only the political will, no, the political will needs to be translated into a contextual practice, and also that contextual practice needs capacity building for those who are going to promote accountability, even before those who are going to promote participation. I try to give an example on the importance of this knowledge construction together with rural indigenous women. We need to listen to them first. We need to understand the way they understand life and health. And that's not easy for some professionals. When we were working with them, even with allies, they were trying to explain how the health system works, and they were talking about the financial arm and the provision arm and things that are not very well, very useful for women to make a more informed participation. No, because professionals, we are formed like that. We are trained to do technical things. So there's a whole technology of participation that also needs to be developed in the country. And the governments used to leave that technology to NGOs or civil society organizations. They never see promoting participation and democracy as their practice. And we need to retake democracy as a concept and a need if we are talking about advancing to any sustainable development goals or that. So it's not only numbers. It's also process and how you approaches. No, it's not accountability is not an afterthought. And unfortunately, still our governments are seeing accountability like that.
Yeah. Yeah, very important point. Yeah.
I believe exist in Romania laws and strategies from since 2007 with the European Union become part Romania. But how to push the government and the parliament to apply. So that is the key. Exist laws, there is rules. The people have the right to go to medical assistant everywhere, but it's not applied properly in how community needs. So I believe our work, like NGOs in some projects, we've done this and we keep accountable the government, but it's very difficult for a small NGOs, 2 or 3 of us, have to be affiliating the some coalition, big coalition, maybe international coalition, and to push them to apply the rules. It's so sometimes it's so simple. We have the rules, but we are not applied. It's how to make that work, and how Renu says before, it's very difficult with the COVID-19 to put something else in agenda. Now it's about the strategy of vaccination. People didn't want to be vaccinated in the Roma community, and women more than that, because they don't have the education and the information right. So what is our needs and what is the most emergency now? To teach them what about the vaccination and to keep family safe, and what about the other rights. 1 year from now, we put all something in the second, in the backstage, and we speak only about the COVID and what is good for them, to give them water. 30% from the Roma communities don't have water in 2020. So the struggles, it's big, and without to be in coalitions and without to be united from all over the world, we cannot push the political agenda in our concern.
Yeah. So thank you. I think what is coming out is the need for, and I would like to actually invite Sarah and Masuma, who have raised some of these points here, to engage with many of us in COPASA to do this realistic research and of what works under what conditions, so that can be then used for advocacy. The other point that I wanted to make was that those of you who are present with us today who are not members of COPASA, I would urge you to go to the website and explore it and see what we've been doing, and do become members of COPASA and engage with us so that we can strengthen our practice, our coalition, our movement for accountability, which is citizen-led. Laura is raising one question. She's saying, would you say that people-centered accountability practices might be incorporated in mechanisms for donors' accountability? Would this be applicable, or should these be kept separate? I think that's a very important question. Would one of you want to answer that? Ariel, Eugene?
I absolutely agree with Laura on this issue. I cannot be more in agreement. And that's what I said when I said accountability cannot be an afterthought, cannot be the last line of a donor's package. And of course, accountability is not to donors. Accountability is for the people, and donors should understand that. As I said, it needs some kind of participatory governance technology, technology understood not on very complex things, but a set of prerequisites to make a horizontal participation effective in this capacity building for both sides, information for people, the rules of the game of the gathering for governance and accountability, the way decisions are binding decisions, because if not, it's going to delegitimate, etc. And here we have challenges, and I will go very quick on that. No, government has never assumed the cost of citizen participation. They want poor women to walk 8 hours to the city to have a meeting of half an hour or 1 hour, and they don't attend that this has some specific cost and opportunity cost for the people to participate. They want just NGOs to finance that, etc. In Latin America, we have seen also in terms of participation recently the co-option of leaders, community leaders, towards the government, towards partisan political interests, because they begin to become important. There are issues of corruption that we need to address. We need to give light to issues of corruption in terms of some corporate interests that now finance some social organizations, just for example, labs that want to introduce one medicine in the national package of medicines, and they even create their own social organizations to press the government. So there are many issues that we need to attend from the external side. But also there are internal issues of civil society that needs more maturity. For example, sharing leadership, downplaying their own power relations, incorporating the leadership of women in a more decisive way, incorporating young people on the leadership of social organizations, articulating, as it has been said, we cannot be fragmented if the fight is the same. We need to find the common language. And finally, the advocacy skills that we need and the social mobilization skills. So there's a complete package of things that need to be done. And this government needs to be involved in this. It's not that this is something for only donors. And I agree, donors should place light on this. In Peru, we have economic progress, but we don't have democratic progress within the social sectors.
Yeah. Thank you very much. We just have about 2 minutes left, and we were a very small group in this room, but I think we've had some very, very important points which were raised, questions that were raised, and responses that were made. And I think this is setting off a process of thinking. I myself feel a bit frustrated because of the way we are doing this. Ariel and Eugene and I have the privilege of showing ourselves and voicing ourselves, but we don't have, you know, the same sort of space for all of you to be able to participate equally. And I find that not very pleasant, but those are the constraints under which we are working. Finally, I want to end with the fact that we are missing Luz and Sana. Both of them were critical for this session, and I'm really sorry that they were not here. Eugene, would you like to say something? And then we will just close with a warm thank you to all of you who have been present with us today, and also to Julie, who has been providing us the technical support. Eugene, over to you, and then we will close.
Okay, I agree with Ariel. It's very important, the donors, since 20 years in Romania, government never give financing for the NGOs, and to keep them accountable depends a lot of work of us, and also to have partner donors. So that is my last chance. So thank you very much for the opportunity giving us to present the Roma movement in Romania and maybe a little bit from in Europe, and the next conference to be each other in some place to drink a coffee, and will be better dialogue. Thank you.
Thank you. So Julie, you could now take us off air. Thank you so much. Thanks a lot, everybody, and bye-bye.